Happy Friday. WebCME wants you to start your weekend with a win. The Clinical Connection Friday feature is Contaminated, Colonized, or worse. I'm quite confident not many of us would have any trouble identifying this wound. This patient is being infected. But how about this wound? This patient has been stalled for months, not healing. What are the issues with bioburden and potential wound infection here? Well, in order to address this situation, we need to answer this question. How do I know if a wound I'm treating is infected? There are a number of elements to this. Does the wound appear red or swollen? Is there purulent drainage or foul odor? What is the appearance of the area around the wound, the peri-wound? Very important. Does the examination find exposed bone or deeper structures? We also can ask, is the patient febrile? Good sign of systemic involvement. Are there findings to suggest that the patient is septic, hypotension, tachycardia? Are there abnormal laboratory tests, such as an elevated white cell count, SED rate, or C-reactive protein? Is this infection potentially suggested by radiological studies, such as X-rays or nuke scans? And are the cultures positive, both tissue and blood cultures? Those questions can help us to define a wound infection, but we need to understand some of the terminology related to wound infection as well, such as wound contamination. Wound contamination is the presence of non-replicating organisms on the wound surface. We know that all wounds are contaminated. These contaminants come from a variety of sources of microflora in the environment. Colonization is the next step, if you will. It's the presence of replicating organisms adherent to the wound, but there is absence of injury to the host when those organisms are replicating. And we know what the common organisms are, skin flora. When we become critically colonized, however, we have a change in the scenario. Critical colonization is synonymous with infection. The bacteria are present in sufficient numbers and with virulence to cause actual tissue invasion and a host inflammatory response. Many of these wounds become critically colonized with high bioburden loads, typically described as those wounds that have greater than 10 to the 5th microorganisms present per gram of tissue. Infection is therefore the presence of replicating organisms within a wound that invade tissue and cause local destruction as well as a systemic or local host response. And again, we have specific organisms that primarily are responsible for causing infection. I like to describe these terms and think about it in terms of the bacterial continuum, the infection continuum, if you will. We start off with contamination. Once again, that's the presence of organisms on the surface of the wound. Many times the wound then becomes colonized, and that's when we have replicating organisms on the surface of the wound. But you notice they are not invading the tissue, they are not causing a host response. When we get critically colonized, not only do we have the presence of bacteria with replication, but now these bacteria are starting to invade the tissue and elicit a host response. And as we mentioned, critical colonization is typically synonymous with infection. Infection can be declared on both a local viewpoint or vantage point or a systemic vantage point. Local being the wound and the peri-wound tissues themselves, systemic, deeper structures as well as throughout the body. And when we have a progression of infection, it typically will go from a local response to a systemic response. When we have a local response, we'll see redness and warmth, induration, pain, drainage. There's increased odor. And the extent of the erythema is localized to that area around the wound, typically described as being a diameter of a wound outside of the wound margin. When that erythema extends further, or there are signs of fever, chills, sweats, hypotension, tachycardia, we then start beginning to think that that infection has spread to a patient on a systemic level. No doubt this patient with necrotizing fasciitis, gas gangrene, is systemically infected. It's no longer just a local invasion of the tissues, but rather this patient is hypotensive in the ICU, intubated, getting ready to go to the operating room. This wound obviously is stalled. It's stalled probably because of a local response. And we need to be able to address this wound from a bioburden standpoint to determine, is it colonized, critically colonized, or infected? We need to understand these terms as wound care practitioners. Well, that's this week's win. We hope this clinical correlation will enhance your wound care practice. Be sure to send us your questions and follow us on Facebook, Twitter, or LinkedIn. Please enjoy a safe and relaxing weekend.